Laparoscopic anterior radical antegrade modular pancreadosplenectomy, or laparoscopic anterior ramps, is a safe and effective procedure which adhere to the oncologic principles. With laparoscopic approach, the patients would recover quickly. The left adrenal gland is the structure that defines whether it is the anterior or posterior ramps. In anterior ramps, our dissection plane would be just anterior to the left adrenal gland in adrenal vein, just behind the anterior renal fascia. The patient was a 43 years old female who had performed a CT scan to work up metastasis for her breast cancer. The CT scan revealed a 4.5 centimeters cystic solid mass at tail of pancreas. Malignant cystic lesion could not be ruled out. Operating team position and port position was as figured. After the camera port was inserted and pneumoperitoneum was done, the trocars were put in place as previous figure. Gastrocolic ligament was resected. Short gastric vessel was also cauterized. Continue resection until we got good exposure of the lesser sac and pancreatic body. Lifting the stomach up helped us stretch the celiac trunk, then we would control the splenic artery as closest to the celiac trunk as possible. The peritoneum was dissected to get into the posterior of pancreas, to control the splenic vein, and also defining the dissecting plane of anterior ramps. The splenic vein was seen here. Then we would want to get as closest to the superior mesenteric vein as possible to obtain a good resection margin. After all splenic vessels were controlled and we were satisfied with the resection margin, the splenic vessels were then resected. Starting from splenic vein, followed by splenic artery. The pancreas was encircled, then we continued dissecting an anterior ramps plane. The earlier dissection made the pancreas more mobile that we could lift it up. Now we could locate the adrenal gland and the renal vein below, so we just keep dissecting above these two structures until we got around the spleen at the end. The spleen was detached from the splenic flexure. Be careful not to get too close to the lesions. Just keep dissecting anterior to the adrenal gland, to the left of the patient. The 10 mm port was replaced with a 15 mm port. We used the Signia endoscopic stapler, together with the extra thick black cartridge staple. To prevent postoperative pancreatic fistula, we applied the prolonged peri-firing compression technique as described by Nakamura in 2011. After firing the stapler, we continued squeezing the parenchyma for 2 minutes before releasing the trigger. The pancreatic stump was checked whether there was parenchymal break or bleeding spot. The last remaining sphenorenal ligament was resected. The specimen was put into a plastic bag and was removed via the fan and steel incision. Applying fibrin sealant on proximal pancreatic stump. Closed suction drain was placed for detection of hemorrhage. Then, the abdominal wall was closed and the skin was sutured. The operation took 6 hours and 6 minutes. The patient recovered well. Histological report was solid cystic pseudopapillary tumor with vascular invasion. All resected margin was free. Thank you for your kind attention.